what this is about, and then I'll go through their names and I'll have them introduce themselves because they know themselves best. But this is cancer treatments through a pandemic. How has COVID-19 impacted cancer patients and oncology departments? We will hear from the doctor's perspective as well as the patients. They will discuss what was different and how things were handled. This panel will help our healthcare professionals know what their patients are experiencing and what they should expect. So let's start with Matt's here. Matt Pond, would you tell us a little bit about yourself?
Absolutely. Grew up in Idaho Falls, and I had cancer when I was 35 years old, brain cancer, and so I've had to learn everything again, where the cancer was, and blessed every day to be alive, and yes, and cancer free. Yeah. Truly amazing.
Cheryl Bellamo.
Yes, I'm Cheryl Bellamo. I am an oncology nurse navigator from the Cancer Center at Cedar City Hospital. I'm not familiar with the concept of nurse navigation. My role, I'm a registered nurse. I'm also oncology certified, but my role is to work with patients and their families very closely from the time of diagnosis throughout what we call the cancer continuum, through their treatment, onto survivorship, or even transition at end of life. But providing them with education, providing them with resources, addressing any barriers to the care. And I think most probably being that hand to hold to be there for them throughout that journey.
Excellent. Thank you, Cheryl. Dr. Haslam.
Cheryl, I've got part of this. She's also the boss of everybody. My name is Derek Haslam. I'm a medical oncologist. I was actually born in Vernal, Utah, and moved to St. George when I was in elementary school. I actually grew up here in St. George. I went to school at the University of Utah. I've been back down at St. George for about over 13 years now. So it's been great to be back. Come on down. So obviously my heart is in rural medicine because of where I grew up and where all my family lives and everything else. So part of what my role is to help with our outreach and tele-oncology services as we've gone out to different rural communities. And I treat all kinds of cancer, but I tend to concentrate on breast cancer.
Thank you, Dr. Haslam. Shelley Smith.
I'm Shelley Smith. I work with the Utah Department of Health and the Health Program. I guess my role is a little bit different, but I like this combination because it just sort of moves right on down the continuum of care type of thing. So my role is reaching out to women for screening for breast and cervical cancer, and trying to get them educated about the importance of screening. And really, when you look at cancer, screening is vital. Control it, but if you can diagnose it at stage, there's a much higher rate of living longer, which is a lot of people, and really that's where my role comes into. I was born in Idaho, but I moved to Shane, lived there for quite a long time, and then here, and so I pretty much spent my life in those areas, and that's where my purpose is. Really need to work on reaching out to our disparate groups that are so vitally important. But really, I think a lot of people are actually living in rural areas with so many barriers, and so we just need to reach out.
Thank you, Shelley. We're so excited to have you. I'm just going to get started up. I've got some questions, and there's one piece that came out in the American Society of Clinical Oncology Journal by Pat et al. Recently. The title is Impact of COVID-19 on Cancer Care, How the Pandemic is Delaying Cancer Diagnosis and Treatment for American Seniors. And they concluded the current impact of the COVID-19 pandemic on cancer care in the United States has resulted in decreases and delays in identifying new cancers and delivery of treatment. These problems, if unmitigated, will increase cancer morbidity and mortality for years to come. How has if we go back up to the original question, how has COVID-19 impacted cancer patients and oncology departments in your world? So anyone that would like to go first? I talked for a moment with Dr. Haslam about that.
Yeah, I'm happy to speak to that. So I think there are some, I would put it into 4 different categories where cancer services were affected by COVID. I think first and primary importance is what was alluded to in that article was that our cancer screening rates dropped very dramatically in the very beginning. And a lot of this because everything was shut down. We were trying to be very careful about who came into our facilities and didn't want to spread the virus. And I think if I recall, and you would know the statistics better, but at least nationally from March to June, when the pandemic first started, those rates of like screening mammogram, screening colonoscopy, and screening for cervical cancer dropped, or it was like 90% drop, which is very significant. Like we spent all these years trying to get people to go and do these things, and then to suddenly have the bottom drop out. And so that was the big fear, is that these that we would end up getting all these late stage cancer patients. And so that was number one. I think number two was just the ability to see patients and do exams on them and meet with them and talk about certain concerns. This impacted not only new patients, but also patients who are on active treatments and who are needing to be followed up for surveillance. That was a big thing. I think the third thing is the ability to actually deliver care. So the infusions or medications, there were all kinds of problems with like supplies and supply chain, and the ability of patients to come in and get those things. And I think I would say the fourth thing, is that the lifeblood of a cancer program is clinical trials and research. Getting the latest and greatest, and that's why we do so well with a lot of cancers now, is because that's continuing to progress. But that was totally shut down during COVID and has had a really hard time getting ramped back up. So these life-saving kind of newer medications, newer treatment modalities, they were shut down.
Thank you, Dr. Haslam. Cheryl, what about up in Cedar City?
Yeah, I like to ask that. You're absolutely right, Dr. Hassan. We saw that shutdown of screening. We saw the shutdown of patients being able to get into healthcare facilities, whether they're PCP or beyond. And I have to tell you, we saw the caseloads drop. We're working with the new patients, but as a navigator, I'm continually trying to work with my patients that are currently under care. And they were greatly concerned. They were concerned about delays in their treatment. They were concerned about those supplies being there for the healthcare teams, whether it was the healthcare teams' PPE or their chemotherapy drugs. Patients that were able to take their chemotherapies at home were still greatly concerned about their shipments being impacted. Patients were very concerned about the healthcare team in general. And I worked from home for 5 months. The navigators were pulled out of our system and sent home. So my work was tele. And to hear them every day, they were, Cheryl, how's the team at the center? Are they okay? Are the doctors healthy? Because they were concerned that if their healthcare team started going down, who's going to care for them? Because they were seeing what was happening across the nation on the night. So that was very concerning for them. So it really impacted not only their care, but impacted them emotionally. And that was very, very hard for patients. They were fearful. They were fearful of having to go into the hospital for scans, whether they were a new patient or a patient that was currently under treatment. I talked about patients constantly throughout those days, and they were afraid. They were afraid to go in and get their follow-up scans. Does not really need them. I feel more safe being in the chemo suite getting my treatment versus going into the hospital getting a scan, because I know the people in that treatment center. I know what they're doing to keep themselves safe. I know what they're doing to keep the equipment clean. I what's happening in the hospital. So we had to kind of continually reinforce that we were all taking safety measures. It was very, very emotional about people for patients. And when the floodgates opened, they opened. And when the screens started coming back, or patients started returning to their doctors, we saw the rise in cases of cancers and more greatly earlier stage.
Yeah.
Something we were very fearful for.
Thank you, Cheryl. Matt, from a patient perspective, did anything change for you for follow-up treatments?
I wore a mask. and I got vaccinated. And yeah, for me, at the point now, I only go in once a year. And so it's not a big thing. I have family though that were doing it, every month, and that it is a harder thing to do
Yeah.
to be able to make sure that they will be safe.
Yeah.
With the treatment and with the people around them. And yeah, it was tough.
Did you have any fear, Matt, going in as a patient? I mean, you've been vaccinated, you had your mask on. Did you have any other fears with, we've had the big C, now the other C?
Oh, and I really didn't. That was just me. I felt like, okay, but I'm in an area where I'm not around a lot of people, and so it didn't really upset me at all that way. But I also know that places where they have people around all the time, that would be very scary.
Yeah, thank you. I'm going to get to Shelley in just 1 minute. My sister's undergoing cancer treatment, second breast cancer on the East Coast, and she sent me this text. My care is the same 100% patient-focused care. It is different in the respect of the process, the security checking in process and minimizing people in and out of, she's at Dana-Farber Cancer Center in Boston. Everyone comes in, has to fill out a COVID questionnaire, standard 6 feet apart. Everyone gets a new mask at check-in. I don't think they are in fear as much as they just want to get better, but it's an added concern, unfortunately. Just thinks people are here battling the big C and now have to worry now about another big C. Just stinks. So that's from somebody who's currently undergoing the treatment. The 2 C's that cancer is big enough, but then add COVID on that, even if you are unvaccinated, we all know with treatments, especially chemotherapy, your immune system, you can catch a lot of things. So yes, Dr. Haslam.
Let me just add this, something you said there, or that your sister texted you, reminded me, when we first started having patients come back in, we had the little limit who they came in with. And so I think, and it's such an emotional diagnosis, and you always want to have as many ears as possible in the room when you're talking about it, so everybody, that whole support system understands. And that was big and something that, I should have highlighted a minute ago, but so that emotional support was not as readily available.
Yeah.
And it became a big issue.
And I'd like to add to that as well. Cancer patients in the time of diagnosis, they're dealing with fear, they're dealing with anxiety, they can deal with depression. Now during the time of the pandemic, because what's happening in the world, they're fearful of their diagnosis, they're fearful of what's going to happen, they're fearful of the unknown, and then they get fearful of what's happening in the world, further contributing to their depression, and it's very difficult for them to cope. Now you add on that cut of support system, they feel isolated, we feel lonely. During my 5 months of working from home, I took great effort in reaching out to patients, continually checking on them to make sure they were okay. And the conversations weren't just about their cancer, or I certainly didn't want it to be about just COVID. It was what were they doing to take care of themselves emotionally at home, whether it be simply discussing some new hobby or discussing some crazy recipe, something they wanted to talk about, because it needed to fill in that gap, it needed to fill in that loneliness, that isolation.
Yeah.
So it becomes very impactful. Typically, when I'm in the clinic, when a patient arrives for their first day of treatment, I'm the one that takes them from that waiting room area into the chemotherapy suite, into the radiation vault, introducing them to the team, telling them how this is gonna flow, what we can expect, let's review how it's gonna flow. What I needed to do during my time working remotely was get a little bit more creative and call them the day before and say, okay, so it's time to review, let's talk about tomorrow's visit. And take them step by step, who they were gonna meet and how it was going to go. Once we take down that isolation, because they were gonna be there alone without any support.
So providing that presence as much as you could, you went the extra mile. Yeah, excellent. Thank you, Shelley. Let's, so how in your world, how has COVID-19 impacted cancer patients and oncology departments? What have you seen from your perspective in your office?
I think, like Kevin said, there's those key issues. I know for the city, just from what we have seen in our from March to April was actually the most and then we worked with 30 hospitals, almost all of the hospitals totally shut down, which is important to notice because that's when everything went. Well, you've got to understand, Utah for mammogram screening is 46th in the nation, so we have really low screening rates. And for cervical cancer, we're and that's mammograms every other year. And so when you hit bottom in 2 months and no screening is growing, it causes a lot. And so the hospitals were really good about starting and getting back. So we have 3 mobile mammogram units. We Intermountain Healthcare, Huntsman, and Garfield, which is part of but they closed down, and it was more than 2 months. And some of the ways that we get to rural areas and communities that are disparate or not as trusting is to use these mobile mammograms because they can work with community organizations. Clinics bring the mobile mammograms right in their area. They can go and see a trusted provider and then go right out to the mobile mammogram unit. And that closes down. And so that took our access to those patients or to those people almost completely away. And so it's really difficult to say that. But one of the other things that we did see is unemployment. And so if you're unemployed, the last thing my is to go get health screenings. And so you get a lot of and then you get cancers of late stage diagnosis. And so we're really just finding out what's going on with people that have cancer and having a lot of them. Walk around the house. And that is a normal thing. And so when you get COVID on top of that, it's devastating. And then you get all of this government and political stuff going on, and people don't know who to trust anymore. And so I think that's one of our important messages is to give good data, give good information, and provide a setting where people can work with community health workers within their community to reach out and get the screenings that they need. But we have to be able to reach out to them.
To provide them the information. Awesome. What a great panel you are. You know, speaking of supply chain, it was mentioned a little bit ago. How has that impacted the field with working with patients and yeah, Dr. Haslam, I think you mentioned it earlier.
Yeah, in the beginning, it was really, everything was focused on gowns and masks and goggles. Yeah. So there was a lot that was going on there. So everything was focused on that. And so kind of on the back burner were the medications and chemotherapies and that sort of a thing. And then I also remember, I feel like it was early spring of this year, although it all runs together, that there was a major storm in Tennessee or something. And surprisingly out of Nashville, like all the chemotherapy, anti-cancer drugs. Yeah, is it FedEx? That's what it was. And so it got shut down, and so for 2 weeks we couldn't get any medications, And so we were having to put off treatments for patients and that sort of thing. That was really kind of scary and disconcerting for not only the patients, but also the docs. We were like, gosh, what should we do? You know, are there some alternatives we could use? And okay, who's actually okay to put it off for a little bit of time? You know, how aggressive is this tumor? Could we, if it went 2 months without us doing anything, we're gonna run into trouble. So I think there was that aspect, and then going back to just the ability to get into facilities. I mean, a lot of hospitals had to shut down surgeries, and so I remember in the beginning of the pandemic, we had a regular, I think we did it like 3 times a week, where we review all the breast cancer cases that came through, and we would talk about, okay, is this somebody that if we did a mastectomy, they could avoid having to get radiation and chemotherapy? Can we present that to the patient as a possible option so that they could just have their own surgery be done and then go into follow-up? Or is this somebody that, is just more aggressive, so they're going to need everything, and so we got to get this done right away? Or is this a really kind of a low-grade tumor and somebody who's really low risk, and can we start them on a medicine like tamoxifen and just really hold it at bay? So we had this, it was good and bad. I mean, nobody ever wants to be in that sort of situation, but it was just really awesome to see everybody come together and just focus on each one of those individual patients and come up with a different plan for each one of those individual patients.
So a different kind of a risk assessment during COVID, different questions, right? Yeah. Anyone else have anything they want to say about supply chain? I wanted to get to telehealth. So telehealth pre-pandemic, telehealth when it really, we were in the thick of things with the pandemic, we're still in it. What do you have to say about telehealth? How has that changed with COVID?
I would say we were Intermountain, thanks to Dr. Derek Haslam here, we were in a very good situation. We had already started to reach our rural areas. So I felt we were pretty capable to jump in compared to a lot of major facilities across the nation. We were already primed to get it going for our patients. Thanks to this.
Well, there's a lot of people involved in that, but but it was nice to already have that infrastructure set up, because we had process flows, but it's different. It's different to take care of somebody and how you check them in and have a conversation and stuff than it is to see them personally, obviously. And so that part of it was nice. I think we were really well equipped for that. I think the one thing that post-pandemic has been nice is that, well, I think 2 things. Number one, when it first happened and the United States went into these emergency orders, and so it dropped any sort of barriers to who and where you could get telehealth, and even these virtual visits. 96% of Americans have a cell phone, and so doing virtual visits like in their own hometown or through their computer, web, or through the web was also something that we could do, thanks to that emergency use authorization. I hope that when this passes, that doesn't go away. So that's what we gotta lobby for. But then the second thing is patients became much more accepting of it as well. So I was actually surprised when we started our tele-oncology program several years ago that there weren't a lot of barriers for patients. Patients it didn't bother them as much as I thought it would. At the same time, there were still some that are a little bit resistant, like, I don't know, how's that going to work? So, but I think post-pandemic, those barriers have been resolved. Everybody seems to be very open and understanding and willing, and even chooses that. I personally will never sit in the doctor's office again in my life. I'll just make them call me. I'll be sitting in my home. And I'll wait for them. That will be my waiting room. And then they log in and say, look at my lap. That's fine. It's a good thing.
Yes.
I do have a question about, are you seeing more rural disparities around comfort than access to technology and using the technology? Because I'm an investigator on some research institute, and I've done a lot of interviewing of women who've been diagnosed with gynecological cancers during the pandemic. And those who are from more rural settings, when we see the whole Northwest, all the states aren't comfortable communicating with their gynecologists via telehealth. And how do we overcome that? Again,
Did you say are not? Yeah. So from my perspective, and we haven't done any studies necessarily to look at this, so it feels like it's more of a generational.
Yeah, I think that's part of it.
Yeah.
Super rural.
Yeah, no,
Yeah.
I totally agree.
Yeah.
And I think that, so I do a tele-oncology clinic out in New York, for instance. And when we first started it, the internet connection was really spotty.
Yeah.
And so we had a lot of problems with that. And, when a storm comes in, I'm not a tech person, but for whatever reason, when a storm comes in, like the Wi-Fi is not quite as good, and so there were those situations. And so if they had a bad experience in the very beginning, it puts up some barriers in order to go back to that. I think that a couple of things that have helped us with that is when we call to set that up beforehand, we ask about their comfort level with it. If it seems like they're expressing any reservations at all, we ask if there's somebody in their family who could be there with them to help with the kind of the tech side of things. And they usually choose somebody who's a little bit younger, or maybe it's their 12-year-old. They seem to really get it. Yeah. The other thing is, I think our platforms have evolved and have become much better and user-friendly over the last year. Whereas, so before they'd have to log on at a certain time and password and make sure it all worked out. And now we can simply send them a text or email, and there's just a link that they can log on, or that they can get, and they're on that full. So I think that part of it, just with the evolution of the technology, will get better. People become more and more comfortable with it. I also think that what is going to make it successful is to have our providers really champion and really talk to the patients about what the benefits are. Okay, you don't have to drive 300 miles. I can do the same thing with the same labs or the same imaging, and really express a lot of confidence there. If you can get not only the provider that's calling in or providing that tele-oncology visit, but also the community and the community docs and providers that are there that say, oh yeah, this is an awesome service, like it's great, and we're in contact with that person. So developing that relationship with the people who are on site becomes key critical. They become the most outspoken advocates of doing that.
And there will always be the patient's family that say, I really want to have that first visit in person. And then they have that visit with you, and they enjoy your comfort level with you. They're like, oh, yeah, I can do this for my home. So they look to developing that.
I thought, so one thing, when we very first started in Richfield, was our first place we did tele-oncology, like 7 or 8 years ago. We said that, hey, your first visit, why don't you come and see us, and we'll meet in person, and then subsequent visits will, so we offered that. Nobody took us up. Maybe it's because of the winter, and there's this rivalry between Richfield and Cedar City, so the high schools don't like each other, the mountain pass. But I was just really surprised that nobody wanted to come and see us in person. They just said, we'll fine, let's do this first one via video, and the subsequent one will be on easier.
I want to ask, Chris, did you have a question?
I did. I was wondering about other services, aside from the doctor visit, what about social work and other related supports, and people who can connect with them and support the emotional as well as resource availability? I worked for a time in Boston in Bethesda Digness Medical Center in oncology, and my job was to help access insurance benefits, give them the medications they need, prosthetics, wigs, all of those things. Are there avenues for those resources to reach but patients in rural areas where they have that kind of support for social work?
And we do. We have social work through our oncology program. Not every facility within Intermountain has a social worker present. So as navigators throughout the system, we can fill that gap in, and we do a lot of social work. But we also have access to the social workers that are within our system to help connect those resources. And as I alluded to earlier, the emotional upheaval, that support that kind of got disconnected during a major part of the pandemic, the navigators really need to fill that gap. And we were able to try to do our best to do that because it really was needed. We needed to make sure that our patients had the resources. I work a lot with Shelley's and her staff through their work. What I found through the pandemic is our Medicaid officer was pulled out of the facility And he was always my first contact to say, hey, I have a newly diagnosed or someone's coming down the pipe. They're gonna need the UCCP Medicaid. You need to get that going.
SSI,
And
SSDI.
yeah, and that was disconnected for us. So you had to be creative in trying to work your way through the various systems to get support and get resources to patients. But you're absolutely right that patients were used to be able to walk into that center pre-pandemic and see their team and be able to have it, not say social worker right on site for particular problem. And that was disconnected. We had to become creative.
I wanted to ask about best practices. I've heard a few. I've heard give them information, be present. Like Cheryl, you were saying the day before you meet with them. And then like virtual kind of it's taken on a different level. Matt, I want to come to you and ask you, if you were to sit down with a group of cancer patients who are fearful to go into their office right now during COVID, what might you share with them and best practices that have worked for you? You're going to hear about this during the keynote, but just a little skinny right now, Matt.
They've got your back. I was so thankful for my doctors to first of all let me know exactly what they were doing, and then comforting to know, hey, this we can deal with the cancer. Don't worry about that. You just kind of worry about how you're doing now, and we will help you get through that. And I would tell that to people that are just finding out that they had the cancer, that they are going to do all that they can for you. They're here for you. I'm so thankful for all of the doctors that I had a lot of chemo from 8 different kinds of chemo, and they were like, this one's not working, we're going to this one. This one's not working, we're going to this one. And doing everything that they could to get me where I am now. And I'm so thankful that they kept on going until they found something that would work.
Where's the positivity come from?
Oh, that it's kind of a state of mind for me. You know what? They'll do the very best that they can do. I need to do the very best from for me, and to not get down on, try to be as positive as possible.
Chemo number 8. Woo, right?
It did it.
I love it. Great. Thank you, Matt. Thank you. Shelley, from your perspective and your role, what have you seen any new best practices evolve? I think you mentioned information. Is there anything else that you've seen from a clinic perspective or clinicians, and even some best practices that patients have had to kind of take on? Have you seen any of that?
I don't know if it's so much of the pandemic, but we're starting to see more information coming out. American Cancer Society did a research on how who the public trusts the most. And in that research, 68% of the people that were surveyed said that they trusted their personal provider the most. And then 48%, or no, like 60% was a general provider. And then government and state health departments. And so I think we're seeing a big shift in who the public has always trusted the providers. I don't know if the providers really understood how important they are. And so I think as we move forward, that we really reach out to providers and say, okay, we need your help. Let's work together on educating them to the cancer screening for you, how we can let people know, because our program is free. The biopsy, ultrasound, additional groups, and then referral to treatment through Medicaid. And so it's really, as a lesser trusted source of messaging, it's really the providers that we need to get out and say, can you help us pass this message along? And ACS also did a lot of different messaging with different age groups, genders, the income level, and they come out with different messaging that would really help providers in saying, okay, this is what things, messages that resonate with different populations and cultures. And so I think that is a little bit different than what we've seen in the past.
Yeah.
Is trying to get that information out more, because providers are really one of the top trusted sources.
Where's that information?
For the public, we can see that. Matt is a perfect example of that. He's just praising his providers, right?
Yeah.
So just to get that message out, that there's so much information. The problem is the conflicting information. When to be screened, how often, when to start, what that means.
I love that. I love to hear all these resources, and you're right, that information needs to go out so people know that it exists. I wanted to ask a question about contingency plans for unvaccinated staff. So we won't go into politics or anything like that. But, if you, I'll just try, no, if you're able to answer that, or you feel comfortable, we'd love to hear.
Well, so I can, this is so hard because, there are so many deeply held beliefs with regards to vaccination and it's such a personal thing. And, if you're in healthcare, you're like, wait. But, there's a lot to that question. I think part of the issue right now, or one of the big issues, is the issue, is if you have a federal contract, right? So Medicare, Medicaid, which for a place like Intermountain represents almost 50% of what they take care of. Then if you don't have a mandate, a vaccine mandate or a vaccine requirement, then you can't take care of those patients. And so it puts, especially some of the bigger healthcare organizations in a really precarious situation where then they have to say, okay, we have no choice. Because if we don't continue to take care of those patients, and we can't continue to do that, then not only do a lot of patients now not have any healthcare at all, but also we have to lay off a lot of workers. Because that's half your business. And so it's really, really hard. And so as far as a contingency plan, so Intermountain just came out with this, and it's a requirement, based on this federal requirement. And the contingency plan is this: we'll just have to get by. We expect to lose some caregivers over it, and that's really unfortunate. I think the University of Utah did it a little bit earlier. If I recall, it was like in September after it got FDA approved, and I think they lost a few, not as many as they anticipated, and so we're kind of crossing our fingers and hoping for the same thing. I don't know that there's a really good other solution. We have had these crisis standards in place where we have traveling caregivers, whether they're nurses or respiratory therapists or whatever it is, and we'll continue to rely on those things. We have a big organization where we can kind of shift people to certain locations depending on where we're at. I think the big worry is that we lose so many people that we're kind of back into this contingency standards of care where we just don't have space in our hospitals. That's going to, so we have a lot of stuff in place as kind of backup for that. I just think that we hope that it doesn't come into play.
Thank you. Anyone else on that question? Wanted to open it up for any other questions. Do we have a question? Yeah.
Yeah, can we go back to telehealth for just a second?
Yes.
No,
Marley, yes.
don't misunderstand me because I'm an absolute advocate of telehealth. By the way, I want my physician to know that he's very important in my life. You're welcome, Mark.
She's important in mine because she always tells me about these awesome trips she goes on.
Yeah, and all
That's
the
all I do
trips
is just like
got
sit and
canceled.
listen to how cool they are.
And the ones that got canceled. So I'm an advocate for telehealth, so don't get me wrong. Now, if I recall correctly, the initial work with telehealth in Richfield, you were in St. George, the patient was in the clinic in Richfield with a midlevel provider. Now, as you're doing more and more telehealth in the patient's homes, how do you deal with the lack of a physical exam?
Yeah, so it's a great question. So a couple of things. So we partner with the primary care docs that are there, the providers that are there in that area. And so part of our role is that we make sure that, hey, have you had your physical exam with your doctor and provider? The other thing is it's true that in telehealth, we do rely a lot more on scans and imaging and labs than we would normally. At the same time, that's kind of the way medicine's going anyway. It used to be that, an old nephrologist could, smell urine and detect what kind of cancer they had, or what kind of disease they had. And now everybody just gets urinalysis, or, a good cardiologist could listen and describe the exact murmur and what needed to happen and that sort of thing. Well, now everybody gets an echocardiogram. And so I think that we've become a lot more reliant on those things anyway. And this is very secret, okay? But for a medical oncologist, as an example, sometimes that stethoscope is just a decoration. If you're not listening to like murmurs all the time or chest findings and that sort of thing all the time, you're not going to pick up on it. You pick up much more just based on how somebody looks, what their vital signs are, what their labs are. And, frankly, if you found something anywhere, you're going to send them for an x-ray or a confirmatory echocardiogram or whatever it is. So I think that's how practice is evolving anyway. The cost of those tests and procedures have come down dramatically over time and getting a lot quicker and a lot faster. And they're much more complete. So yes, you are missing that part of it. And I think the other thing you're missing is just that, oncology is a really high touch, high field specialty. And that was the biggest concern I had when starting teleoncology. I wouldn't be able to be there and put my arm around them. And so you do have to rely on the partners on the other end to do it.
I just have a couple questions, comments. So with our breast and cervical cancer program, screening program in Utah, does it cover undocumented? You said it covers less than 250% of the poverty level, but what if you're undocumented?
And the CDC leaves that up to each state.
So what do we do here?
And in our state, we will accept documented screening program. Once they reach, if they have breast cancer, then we have to figure out other ways to give them treatment.
So then they would need charity care, a major.
Right, and
in
then
and out. And I'm an HPV vaccine researcher, advocate, investigator. Do you incorporate HPV education? Because we still have there's a lot, most people still do not connect cervical cancer screening with HPV virus. And we are state number 47. So it's a wonderful opportunity to get that message across in terms of vaccination. So do we incorporate that?
We do a little bit in our program, but we have an immunization program within the state health department, and they really advocate for that. So we haven't done much for our program.
So what I meant is, like, if women are getting cervical cancer screening, like informing them what they're screening, like linking that HPV education, including that component in access to pap testing and HPV testing.
We advocate for that, for the providers to do that.
Okay.
So we do that, and then the pap test is, we always do the HPV test with the
That's great.
pap, so that they get that test. It's combined.
And then are the guidelines every 3 years or every 5 years? Like, what are the guidelines?
With the HPV
Co-test?
and the co-test is every
5.
Yeah. And if they're a younger age, they don't, they get the HPV every 3 years. If they don't have HPV.
And then the one other comment I wanted to bring up was related to earlier in our conversation about lacking social support at time of diagnosis and treatment. But one thing I'd like to mention from what I saw at our Huntsville Cancer Hospital is all the deaths that happened around COVID and loved ones weren't able to say goodbye. So I think that still, we have that group of people who've been really scarred from the pandemic that we can do work to support now. I think we forget about those who've been left behind and weren't able to actually be with their loved ones and say goodbye. I saw it over and over and over. It was just really heartbreaking.
Okay.
Yeah.
Great point. Yeah, Nobody knows, Deanna does some amazing work in the HPV vaccine realm. Like it's awesome. And seriously, like I just been a really big fan. I'm curious, I'm sorry, I'm gonna throw out a question.
No, go for it.
I've been dying to ask you. So with all this, the vaccine contribution, have we seen a decline in the HPV vaccine? I mean, I know we're already 46, but have we seen it even further?
So across the country, HPV vaccination rates have dipped by 20%.
Okay.
In the recent, there was an article in the Salt Lake Tribune where HPV was the lowest, we had the lowest dip compared to all the other childhood adult conditions, was about 5%. But I'm thinking it's because we already were so far down. Like there wasn't a lot of room to decline when you're like already at a third of kids getting it. So we don't know, we don't have the data out yet from the year 2020. And so this is our ACS partner too. So she's in charge of our HPV Mountain West program. I don't know if you want to say anything about.
No, I was just gonna say hi. And thank you for the shout out. It's nice to see the ACS providing some good. But there have been drops, and it's really unfortunate. And I think I mean even the NIS team data that rolled out showed that data was collected before the pandemic hit, so it will take 2 years before we really see the effects of adolescent vaccine drops, which in turn is just going to be.
I want to give a shout out to the Huntsman. Thank you so much for representing. Matt and I both went there, so that's where we met actually. Dr. Crimmins, you have a question?
Yeah, just a couple of comments. I was in Richfield for about 30 years before I left 5 years ago to do some teaching now. But anyway, I think one of the problems in Richfield, as the telehealth and cancer treatments, the problem getting it going there is that they were used to traveling, and the people in all the counties around there traveled everywhere, and they were used to doing that. So it's kind of hard to convince them that they would still receive the same type of care. Another thing, they had to go to Cedar City for their radiation anyways, and why can't they meet in Cedar City? That type of thing for our treatments. That's what we were kind of fighting then, and they felt that they were good enough people. They wanted that in-person visit type of a thing. So I think that might be some of the concern they have there getting it going. My other comment is I've worked in hospice for about 20 years now. And one of the things I've seen through the pandemic here lately is that my referrals for hospice, for end-of-life comfort care, when decisions change after cancer care and other things, is that's dropped off too to what I call brink of death care, where I get the 24-hour referral and that's it. And I was wondering if maybe you can comment a little bit about what you've seen, maybe Cheryl, on routing patients to comfort care, specialty care at end of life, and what's happened there.
And that has been one of our goals for several years through Intermountain, was not to be doing that 24-hour, 48-hour calls to call the hospice. That's just uncalled for. That's just cruel to the patient. That's cruel to the family. I think our team has done a fantastic job in opening conversations up very early in the course of treatments. And this is where we're headed, and making sure that that patient and that family is part of that shared decision making. This is where we're at currently with the disease state. This is what's working, what's not working, and we need to prepare for that and start to prepare that patient and their family for that transition to end-of-life care, to hospice care much earlier. Also, we're bringing in palliative care as well. I'm a huge advocate for hospice care. I worked hospice care, and so I know the impact the value it can have for that patient, that family. So yes, we as a corporation continue to work on that, I also feel that we as a nation need to work on that. There are some big disparities across the country. Patients to hospice care center.
I think, and to speak of this increase in the, rate of death, what we have seen what I've seen personally, and what we've seen as a system as well, is there's been a general reluctance to notify when something's not going well, or because nobody wants to go to the emergency department, nobody wants to come into the infusion centers to be evaluated because they think, oh, I can make it a little bit longer. I don't want to be exposed and all that kind of stuff. And I think we're coming out of that a little bit now. I think some of those fears are starting to take good. But I saw that in the beginning too, especially. And so by the time they finally came in, or we got an awareness of what was going on, it was just really late in the game. Whereas before, that would have been identified weeks and weeks beforehand, and we would have been able to jump on that intervene sooner. I hope that trend that you're seeing goes away.
Yeah, I do. I've seen some concerns though with Intermount and the direction they're going with doing what they're calling respite care in the hospital, when they're identifying people on a late stage, and then they're saying, "Oh, just stay in the hospital a few more days under respite." We call hospice in, so then your death isn't on our books at the hospital, on our records. So they're keeping them in the hospital now, where they're not getting visitation from family and other things because of COVID. I find it a real disservice to patients where they're keeping people in the hospital setting rather than home setting for their hospice.
My question would be, is because that individual lives alone? So many
Sometimes,
hospice groups won't even take a patient if they do live alone. So they use the GIP or the respite category to keep that patient in the hospital setting, or try to look, if available, if there's room in a skilled nursing facility, which isn't already shut their doors because of COVID or not accepting admission. So it's difficult.
It's really been kind of a disservice. I mean, I can't call it disservice, basically, but a hard option for families and patients because now they're in the hospital, they can't have visitation either. They go to a nursing home, they can't get visitation either. It's really been a difficult thing for a lot of my hospice patients.
I want to keep going with this and skip lunch, but I want to hear Matt. Thank you. What an honor to be here and to learn from all of you. Thank you, Matt, Cheryl, Dr. Derek, Shelley. Let's give them Matt, who's our lunch keynote, and underneath your chairs is a gift from us. Thank you so much for your time and everything that you shared with us.
Thank you.
Oh, we did great.
Oh, no.
Okay, 1 second.
I'll talk a little bit more.
Okay, Cynthia, why don't you get up there?
Oh, yeah. Oh, I wanted to get up here when you get here.
Well, yes. 1, 2, 3. Perfect. Thank you guys so much. You did so good.
Good job, everybody. Oh, I learned so much.
I know.